have apologies from Rachel Parsonage, Rachel Beaumont-Wood, Matthew Bryant, but we have Nick online representing him, Sam Crow, but we have Aidan representing him. Welcome, Aidan. Lisa Harwood, Alison Henley, but we have, there you are. Do you want to say hello to everyone?
I'm Jenny Wyatt, for those who don't know me. I'm one of the Deputy Chief Finance Officers.
We have Nick Ireland is online, I think, or not yet. Thanks very much. Paul Johnson is represented by Alison O'Donnell. Welcome, Alison. Keith Falp and Andrew Rosser from SWAST as well. And also we have apologies from Dan Worsley. Should we just go round? I'm sure everyone knows everything else. It's just me that doesn't have a clue, but David.
Good morning, everybody. David Freeman, Deputy Chief Exec.
Go on, Liz.
Hi, I'm Liz Birdsall. I'm Head of Corporate Governance for the ICB.
I'm Steph Lowe in the Corporate Governance team and the Minute Taker.
Jenny Wyatt again. Nice to see you all.
Alison O'Donnell, Deputy Chief Medical Officer.
Morning, everyone. Siobhan Harrington, Chief Exec at UHD.
Morning, I'm Rob Carroll. I'm Director of Public Health and Communities at Bournemouth, Christchurch and Middle Council.
We'll come to online in a moment. Hi.
Morning, everyone. I'm Pam O'Shea. I'm Interim Chief Nurse for NHS Dorset.
And Adrian White, Non-Executive Member of the ICB.
Dean Spencer, Chief Operating Officer for the ICB.
Dawn Harvey, Chief People Officer for the ICB.
Brian Farron, Chief Executive, BCP Council.
Aidan Dunn, I'm
as advertised.
Director of Resources at Dorset Council. So yeah, sorry, online. Aidan Dunn, Director of Resources at Dorset Council.
Tricia Miller, Chief Exec, NHS Dorset.
And then online, would you like to say hello, Nick?
Yeah, morning everyone. Nick Johnson, Deputy Chief Exec at Dorset County and Strategy and Transformation Officer across Dorset County and Dorset Healthcare, here for Matthew Bryant.
Thanks very much, Louise.
Good morning. I'm Louise Bate. I'm the manager at Healthwatch Dorset.
Hey.
Kay Taylor, NEM with ICB Dorset.
Thanks very much. Is that Paula?
Hello, I'm Paula Bennett from Dorset VCSA.
Thanks very much. And I need better glasses. Is that Chloe? I can't quite read it. Charlie. Thank you very much, Charlie.
Morning all. I'm Charlie Green. I'm Chair of the VCS Assembly.
Thank you very much. And who else? Is there anyone else I need to say? Oh, hello, Rachel. Do you want to say hello?
Yeah, hi. Thank you. I'm Rachel Pearce. I'm from NHS England.
Thank you very much. Very good to see you. Oh, I'm very sorry. Forbes.
Good morning, Forbes Watson, GP Chair of the Dorset General Practice Alliance.
Thank you very much indeed. I'm amazingly short-sighted, everyone. So, as interestingly, Siobhan knows I'm blind in my left eye. So look where she sat. The great experience there, Siobhan. But do wave at me if I miss anybody. We have some people attending today, but I'll introduce them as we go through, and we'll go straight into the agenda. So to start with, are there any declarations of interest beyond those that are scheduled that anybody wants to make? As it's my first formal meeting, I declare on my interest that I'm a senior advisor to Newton, and just in case Newton come up in discussion, I don't work anywhere near their health practice and I know nothing about what's happening in Dorset, but as Siobhan will know, I sort of declare it all the time just to be squeaky clean. On this, any other declarations that colleagues want to make? Minutes of the last meeting, are we happy to take them as a record? I'll take that as a yes, thank you. The action log, the recommendation is that everything on there is closed today. Is everyone happy with the reporting that's given on those actions? Yeah, okay. Thanks very much indeed. So we come to standing items. I'll hand over to Patricia in a moment for her reports. I've been pleased to meet many of our MPs in the last month, as well as representatives of GPs, and also been very pleased to meet in introductory meetings other ICB chairs within the Southwest, as well as colleagues here within Dorset. But just a couple of things. I wanted to socialise the formal meeting that came out of the development session that we did a month ago, which was my first meeting. I intimated that I would like to set up a quick working group on governance. I've had some volunteers for that now, so thank you, Adrian and David, as well as David Clayton Smith and Forbes have volunteered. And the plan is that we have a few meetings in order to touch base on where we are with our governance structure and how to make it as effective as possible. Liz, as well, you'll be a member of that. I'll circulate some proposed terms of reference so that you know what we're working on. Any comments or any other interest in the group, please do let me know. At the development session as well, we discussed locality working and how do we make sure before we really sort of get going on the integrated neighbourhood teams that this fits with a local authority view of how locality working should take place. So I wanted to put that in the public domain today, and perhaps Nick, it's something that you could take up with Graham and Aidan / Sam, and I'm sure Nick and Millie and the ICP would want to be involved. But I think getting a shared view of how locality working should take place seemed quite an important action coming out of the development session. If everyone's happy with that, I'll take it that some discussions will take place that can be discussed at the ICB, and a view given to the ICB about as we're going to introduce integrated neighbourhood teams from an NHS perspective, how we fit in with this view of locality working. If that's any thoughts on that. Is that okay, Nick? Thank you. Very much indeed. Lisa isn't here today, but Lisa has let me know that she'll be standing down as a NED. She's very busy in her other work, and so I think has got one more meeting. Is that right, Liz? So we can give our thanks, or even two meetings maybe, or one formal. So we'll give our thanks to Lisa at that meeting. Patricia, your update, your report.
So thank you.
And then we'll take questions together, because it means if I do it that way, Patricia can answer whatever you would have asked me.
Okay, so I have provided a brief update on what is happening nationally from a strategic perspective for the NHS. So you see that there is a confirmation now of who the transition team will be, whilst NHS England and the Department of Health develop their transformation plan to join the two departments together. I know that at the beginning of this process, the Prime Minister talked about the abolishment of NHS England, but we won't be able to do that formally until there's a change in the Health and Care Act that was introduced in 2022, and it's looking as if that probably will take around 12 to 18 months. So this is the transition team that we'll be working with. Jim Mackey published on the 1st of last month the letter out to ICBs that talked about the 50% reduction in programme and running costs, and what the implications also were for providers around the reduction in corporate services growth. There was some quite clear framework within that letter for this work to happen, and we are currently working on the plan that needs to be submitted to NHS England by the end of this month that articulates how we're going to do that. The other things probably just to raise here are the urgent emergency care plan that will be published mid-May. That will then require systems to do some stress testing of that in terms of application to their winter plan. And I think the timetable for developing and agreeing winter plans might move up slightly, so we've got time to stress test properly before the winter. And by that point, we'll be well into the delivery of the future care programme, our urgent emergency care transformation programme. So it'll be pleasing, I think, at that point to start to see the impact of that moving at a faster pace. The NHS performance management framework will be published soon, and it will focus heavily on individual organisation accountability as opposed to the connection to systems. We are having a discussion both nationally and with our regional team about how that will play out in terms of the increased need for contract management performance from ICBs as we move into a wider, deeper strategic commissioning role, and how we align that properly with the performance management and oversight that NHS England will be doing. So we're clear we've got absolute alignment about where the triggers for performance reviews will happen, and so that we're not moving in two different spheres and creating complex narratives for providers. We had two really good events in the last few weeks. One where we hosted the latest workshop for the Coastal Navigators programme that we're part of. That is being driven by Ed Garrett in Sussex, but also being really heavily sponsored by Chris Whitty following his report on coastal deprivation. Excuse me. So having Chris here and really giving some support to that programme was really welcome, and we're making lots of progress in terms of not just tackling coastal deprivation, but also as part of the Get Britain Back to Work programme, supporting local people into local jobs. So I was really proud to be hosting that. And then also we had a update workshop for the work we've been doing on women's health with most of our third sector providers who and networks who've really been heavily involved in influencing this work to make sure the arrangements we've set up for the access for women to services and understanding how they access services has really been co-created with our communities. So that was a fantastic event. We had lots of speakers, NHS England colleagues attended that, and it was a really successful afternoon. So just to wind up in terms of NHS Dorset's priorities for the next few months, and I haven't referred to the ICB reductions in here because we will talk about those in more detail in part 2. The delivery of the operating plan and the medium-term plan that gets the ICB back into recurrent financial balance is obviously a big priority for this year. And we're going to talk more about where we are with the operating plan later in the day, but needless to say, there are still some risks attached to it, particularly in terms of increasing the amount of recurrent SIP that needs to be delivered. We are starting to think through what our contracting and funding approach will be, and for the coming years, and at the June development session, David and I will lead a piece of work on strategic outcome-based commissioning, what the provider landscape will look like at the end of our transformation programmes, and how that then leads into a set of commissioning intentions that we'll be able to publish later this year. We're on track with delivering new models of care to commission for end-of-life services, neurodiversity. We're about to launch a new triage tool to lead into the next 6 months of developing a completely new commissioning model. And the children and young people's mental health business case has been developed. It's been to subcommittee for the first review and has been asked for some further work to be done on that before we can move forward with a different commissioning model for that, which will be a major step forward for us in making sure that children and young people have the right access to all levels of mental health services, and that we're able then in 26-27 to move forward with a zero tolerance approach to admissions for those young people to physical health units when there is not a physical health need. So those are the key points I wanted to raise. There's obviously some updates in the pack also from partner organisations, and if there are any questions, I'm happy to take them now.
Thanks very much indeed. Any questions, please? Graham.
No. Okay, it limits the number of mics that can be on at any one time to 2. So it's a system. And thank you everybody for using the mics. I know it's complicated. Just a question about the potential to restructure and conversations are going on. I was at a regional organising group this morning, and there's just a bit of concern being expressed about potential devolution arrangements which local government is consulting on, and just making sure that the conversations get aligned. Because I think the fear was that there's an NHS conversation about realignment. There's a discussion about there's partially aligning with the devolution, but not entirely. So our devolution deal, which is slightly complicated, is Dorset, so Dorset plus BCP, plus half of Somerset, because it doesn't include North Somerset, because that's likely to go to WECA, the West of England Combined Authority, and Wiltshire, but excluding Swindon, which is also part of Wiltshire. So it'd just be helpful to ensure that whenever there are any conversations going on, that there's a sort of a wider partnership engagement. And of course, police were also discussed in the same sort of light. So just wanted to make that.
No, it's a really good point to make, and we'll talk about the detail of that in part 2. In fairness to us, I have really kept Nick and Millie in the loop about what the options are and what our favoured option is. And I think they feel what Dorset ICB would like to see happen is the right way forward. So I hope that helps, that we've very much kept them in the loop.
It does, and actually part of the conversation today was there might be 2 or 3 steps to this, because actually you have a conversation with Somerset at the moment, it's the whole of Somerset. At a later point, if North Somerset goes to WECA, then there might be a secondary alignment, but just to flag that.
Sorry, in the conversations we'd had with the region, trying to align with devolution boundaries has absolutely been central to that. And the reason why the paper that we're going to talk about today is in part 2 is because we didn't want to be saying anything in the public arena that we haven't yet talked to our staff about, but we will cover that in detail in part 2.
Yeah, and I guess what you know is interesting to say in public is there are always competing synergies, aren't there? And there's a synergy around patient flows between primary and secondary and tertiary, and that's very important. But because of devolution, there are now new synergies around population health and linking to ICPs. So there are competing synergies, Rachel, and you must see this all the time.
Yes. It won't be perfect, but but definitely.
Thanks very much indeed. Any other questions? Thank you very much indeed. Thank you, Siobhan. Forbes.
Yeah, just a couple of comments. Thank you. First, thank you for your report, Patricia. As you know, I always find it interesting. I think just to acknowledge the significant change that's being undertaken. I know it's going to be discussed in part 2 and how difficult that is for all concerned, and the need to be mindful that we need to try and keep the show on the road, as it were, isn't it? And that's difficult for all staff involved. So it's really just an acknowledgement of that. I also heard really positive feedback about the Women's Health Day, Patricia. So I knew people who were there, and they said how good it was, and we are looking to replicate the messages in an event for general practice, and so we can share that learning. I'll just look at the 12 themes that were outlined here, and it's more a comment perhaps for Alison. Colleagues have been involved in early discussions around the referral management centre, and while no one's against that in principle, the concern is that we don't focus on the pathway work underneath that, because the pathway work can then change the pathways to deliver more services outside of hospital, rather than just manage the referrals, actually change the pathways so we've got better services outside of hospital, and that would be very pertinent in many of these women's health issues, which would reduce the demand on secondary care. So just to put a note to say that it would be good for us to really focus on these themes and see what we can do in a different way. And the other thing was around Beverly's position, Siobhan. And Nick, I think it's really welcome to see that we have got someone who's overseeing IT across the three providers. If I look to the end of the report, Louise's comments about general practice, and actually the comment or the example that's given is really an interoperability issue in the IT systems. I couldn't access my results from Poole Hospital, and I think we've sort of struggled to get those joined up functions over the years in Dorset. So if Beverly now has that permission, I see that as really positive and should actually help all the various care process that we're trying to deliver that need the interoperability of IT systems to work well. Thank you.
Thanks very much indeed, Forbes. David. Oh, Siobhan, thank you.
Really welcomed in the report, Patricia, about the priorities in the year ahead. And I think that is just going to be very important for all of us in Dorset, because it actually allows us all to absolutely lean in and be very clear about what we're delivering on over the year. So I thought that was very welcome. I do just want to note from a UHD perspective in the back, we opened officially, this is the first public meeting, so we've opened.
I was going to ask you a question about this. Well done.
And I want to say thank you to all our partners across Dorset, but also to everybody that's been involved in the CSR for many, many years, because I haven't been. And actually, I can absolutely see as we are delivering this, the improvement in terms of patient experience and care, especially around maternity and neonates, but also staff experience is just incredible. So maternity and neonates is well in there. And then just to flag that next week is when Bournemouth Emergency Department moves into the Beach Building, and it's on Tuesday, Wednesday and Thursday next week. So look forward to continuing support from partners through the coming weeks. Thank you.
Yeah, thanks very much. There are lots of good things in all the partner reports, but we ought to highlight the big events about to happen at UHD. And well done, Siobhan, really, really well done, and pass them out. Thanks and congratulations to everybody at where you are. David.
Thanks, Rob. I just wanted a question and then an update, really. The question is, you mentioned in your update about localities and the importance of localities. Is that the same thing in your mind as place-based partnerships, the BCP footprint, the Dorset Council footprint?
Yeah, I think we need to get a shared view of what all of this means.
Yeah, so I wanted, because there's been some really good work in the last couple of weeks on that. I think it might be helpful for you and the board to be aware. So just yesterday morning, Liz and our colleagues met with Nick and Millie to design a workshop for the ICP, a refresh and a stock take on what we're going to do for the rest of the year. Session at the end of May, which will be facilitated by the Confed. So we've got a plan coming together for that, and that will include locality, place-based type considerations. Yesterday also, actually, I think the Dorset Council colleagues met together with partners to start fleshing out what a place-based partnership means in Dorset Council and how that's footprint and how that's going to go. And I know there's been very active conversations in the BCP area around that over the last few weeks as well to try and bring that together. So there's quite a lot moving in this space, recognising the signals coming from the centre about the importance of neighbourhoods and places, stroke localities. We're accelerating some work on that. So I'll catch up with you afterwards to sort of bring you up to speed with that, and then we can take your thoughts into it as well.
Brilliant. Thank you. Thank you very much. And Forbes' question about pathways, David or Patricia, it's important, isn't it? Because if our strategy at the moment is stabilise our finances, deliver 25-26, don't get knocked off course, put lots of focus into delivery, even though there are extraneous things taking place, we have to stay very focused on delivery. But then how do we have shift? And there are options on shift, and do pathways involve community hospitals, GPs? What's the preference? What do we think is best about local? These are real issues to deal with about where new commissioning intent will be developed by the ICB. And I don't know if you just want to comment on that, because I think Forbes' question about underpinning all of this with pathways is actually essential, isn't it?
It's really important, and when we've got a piece of work in Workstream 5 in the operating plan that talks about fragile services and redesigning those into sustainable models and pathways. But I think once we've got past those, we need to do a broader exercise around pathways. And one of the things that we'll be responsible for in the new world of ICBs next year is being really clear about what good looks like, what best practice looks like, what good benchmarking looks like, when we need to change pathway models because the demographic picture for Dorset has changed. So we need to get into that space now and make sure we're leading that from.
Good. Do you want to comment, David? Or?
And I would say that we are endeavouring throughout, despite the pressures and the financial constraints we've got, we're trying to deliver our cost efficiency, productivity and improvement plans through pathway improvement initiatives. So it's not just restrict, cut, change. It is about moving towards better, more effective ways of working. So that underpins the plans. So whilst we're looking to the future, the medium and long-term futures, Patricia's just outlined, we are trying to set that up through the work we're doing this year.
Alison.
I mean, just to build on that, I think the other part, I think, is we have got good clinical engagement. I think we need to build on that, because I think that will really help us to concentrate on that left shift, which is what Forbes was indicating in terms of moving out of hospital, into community, into primary care, into voluntary sector. All of those pieces need to be knitted together. I think the other thing that is going to be really important is the approach around the outcomes-based commissioning, which gives us those opportunities to see whether the things we are doing are actually having the effect that we want, or are reaching the populations that we had intended them to reach, and being able to, at an early stage, say, actually, that's not quite doing what we expected it to do. Do we need to change it? Do we need to scrap it? Or do we need to, actually, it's so good, we need to find a way of accelerating it? And I think how we become much more live in that sort of situation is going to be important, because that's how we'll help Jenny and her finance team achieve the bottom line, and it's what will deliver for our population.
Yeah, thank you very much. Nick.
Yeah, so just to, I guess, amplify a couple of the points there. Certainly in the short term, via the provider collaborative, we're really focused on what we can do differently across the providers, really focused on productivity and recognising the need to deliver and deliver quickly to be able to hit the kind of the plans for this year. And then, Rob, I would really welcome your point around the strategic commissioning intent, and I think sort of starting that work now, so we're in a really good place going into what will be 26, 27. I think it's really, really important. And I think from a provider collaborative perspective, we'd be looking to work really closely with the ICB on that, to give ourselves the best chance of kind of making change as early as possible in 26, 27.
Thanks very much. Patricia. That's the another hand, was it?
I'm getting good at this. Got it. Agent's been pressing the button for me because I'm rubbish at it. Just to add another layer in that, when we do that work, I think we talked about this previously, but we need to think through how we also apply a health economics lens to some of that work, because we've been really fantastic at meeting all the operational standards, but the reality is the way that we do it and our service models are too expensive. So if we're going to get best value out of the Dorset pound, we need to think through really carefully how we bring that health economics expertise in, and not as a one-off, but as a mechanism for really embedding those skills in our team. So when we're doing that work, we've also got that lens to see it through, to make sure what we're doing is the most efficient way of delivering service, as well as meeting the needs of the population.
That's really welcome to say that. And it's clear ICBs will do strategic commissioning, whatever else is happening on the blueprint, and doing that well and doing it properly and building our capabilities on the back of sounder finances is a really welcome thing to hear. Thank you, Patricia. Are there any other? Aidan?
If I can make a point on another
topic.
In terms of good news for the system, I think. So in the report, it talks about the Ofsted inspection that Dorset Council had earlier in the year for children and family services. So it was just published, the results published this morning, and we've been awarded outstanding overall.
Wow.
So that,
well done.
So I just, so well done, thank you. But I want to say thank you for the system. I want to say, because it's a real sort of tribute to the system and all our partners, and particularly the voluntary sector as well, and our families out there. So it's really good and really
well done.
So thank you.
What great news for young people in Dorset. Really well done. I think we can move on, can we? I don't see any other hands up online or in the room. So we will come to item 4, the mental health story and deep dive. I think we're joined by Lucy and Moran.
You've got me. Hello. Lucy's going to give her apologies today. Unfortunately, she's well, so I'm afraid you won't get my jokes.
Well, I look forward to them. I hope they're good.
I'm not very good. Okay, thank you. I would say I have to stand because my brain stops working if I don't walk. Thank you. I'm grateful to engage in this deep dive and patient story. Obviously, it's the context of mental health, Maternal Mental Health Awareness Week. Worth paying attention to that. There was a really good story in the news which preempted us this week with the BBC, and I think it is worth, when you get the opportunity, looking at Lydia and Casper's story. It really kind of talked about how you can have a really successful outcome with an integrated approach across different partners. What I would say is I am going to talk about things from that lens, and one might be aghast that it's just Dorset Healthcare that's talking about mental health, because quite frankly, the primary delivery of mental health isn't just from a single provider. And I guess what I would like to do is just talk about the context of mental health. To do that, though, I'm just you're gonna need to humour me for a moment. What I'd like you to do is just kind of conjure up an image of, when I say the word mental health, what you think about. Just come up with a moment. Mental health, your day to day. What do you think about when you think of mental health? Stop stealing my slides, Pam. Okay. I think that's a really kind of helpful comment. So now what I'd like you all to do is have a think about your day. Have a think about you. Have a think about your stress, your well-being, how you experience the world. Now extend that. Make that pervasive. Make that happen to all those people around you, all the things you do across a day. Worsen it. Make it harder. Now, the question that you might find yourself asking is, how much does that match with the image of mental health when you conjured it up? Is it the same? And it may not be, and there may be particular reasons for that. I'm going to basically talk about the concept of mental health. So to do the deep dive, you have to figure out what we're diving into first. So I'm going to talk a little bit about the history of mental health, why we are where we are, and particularly thinking about where the future goes, and particularly how that is underpinning some of the work that we've been doing across the system over a number of years in terms of building communities. Okay, so I'm sorry, I've got to do the Chris Whitty thing. Next slide, please. Thank you. Okay, so mental health in of itself started off as a medicalized concept. I had the word neo-Kraepelinian removed from my slides. However, there was once a psychiatrist known as Emil Kraepelin, and there was the identification of dementia precox and mania. So what we might now call severe mental illness. And so they were pushed into a diagnostic model. And particularly, we had an asylum system, so where people would be acceptably placed in a particular space. And thus we led with a medicalized type of approach to understanding mental disorder, as it were. That then eventually culminated in a multi-axial system through the, I mean, I'm supposed to use the ICD here, but the DSM-4, which particularly led it, so the Diagnostic and Statistical Manual, which particularly influenced some of what we might call the common disorders, and then some of the severe mental illness presentations. Now, when I say the word severe mental illness, these are illnesses that should be explained by an organic component. So, so the implication is that it's not something that happens to you by interaction with the world. It just is going to happen to you. However, as the evidence has developed, that's particularly changed, and we are all essentially vulnerable to some of these features. And as such, one of the particular movements over the last 40 or 50 years is to have a more nuanced understanding. This is culminated in understanding the nature of trauma and the nature of distress and how that impacts upon people's mental health on a day-to-day basis. It is also giving recognition to the context in which people live. So networks, communities, the nature of isolation, the nature of deprivation, and how that influences somebody's experience of the world. And the particular movement has been around prevention rather than treatment of cure. So particularly, unfortunately, a medicalised type of approach looks at the deficit, looks at something that isn't there, and our approach is the removal of the deficit rather than the creation of something new, the creation of what it means to live a good life. So I often use the term that essentially we're plumbers. I can fix your boiler. I have no idea what a swimming pool looks like. And I guess that's kind of the point in terms of some of the challenges that we faced in trying to move to a prevention-based approach, and how we've then worked our structures in terms of the community mental health transformation work, for example, or some of the work that we have been doing around NHS talking therapies in recent years as well. So I mean, I could go into a bit more detail around, and I'm not sure if people are familiar. Obviously, we don't have an asylum system anymore. There was the essential ending of the asylum system over the course of the 1980s into the 90s, the culmination of the National Service Framework, which then had a particular structure around how we would then provide care and treatment, the creation of community mental health teams. Assertive outreach was a function of that. I'm aware Mark will talk about the intensive and assertive functions a bit later in the session. However, what it culminated in totally is the, and it was a landmark paper, was the No Health Without Mental Health paper, which particularly looked, and I think was, you know, it echoes some of the words of Darcy, and so there should be no surprises when we're talking about how care is delivered, and that's why there was much more of a focus on, for example, NHS talking therapies, which one lined up with a nice guidance, but then also was correlated with empowering individuals to make changes in their lives, for them to be able to make a difference rather than being seen as patients, for example. By the way, I will take questions as needed. I think I have to say next slide, please. Thank you. Okay, so to also understand the context of mental health, it is worth just kind of attending to some of the key headlines around mental health. People's life expectancy is impacted by poor mental illness. Sorry, it is correlated with poor mental illness. I'm not going to encyclicalization. The fact is that people with poor mental health presentations also are likely to live shorter lives, and there are a number of factors associated with that. The fact is that mental health challenges or problems, common mental disorders, for example, anxiety and/or depression, is a common experience for humans, for people, and 1 in 4 people will experience it. We know that also that, and CYPF, the Children, Young People and Families mental health agenda is very much front and centre for our system at the moment as it stands. And we know that 1 in 5 children and young people have a mental health problem, but only a third of those people with the presentation are able to access specifically designed mental health services in the classic form. And I think it's important to caveat that. Some of the work that we are talking about today is about how we're doing things differently, not just doubling our services, because ultimately that's not going to be the answer for society in the future. Next slide, please. The other thing to note is that ultimately we know that there's a high correlation with deprivation and mental health problems. Now that's a bidirectional relationship, so it can be both a cause and a consequence. However, we know that it's highly correlated, and that some of the answers that we have is around how we build society and how we build communities and manage deprivation, as opposed to what is the effect size of, say, a therapist. I say this as a therapist, by the way, and my aim is to do myself out of my own job eventually. Okay, so if we move forward one slide, please, thank you. The other thing to also, apologies.
We found that with the mental health access and wellbeing centres, that actually, you know, some of the pilots that were done in North West London around placing mind in ED have been really clear on, you know, the evidence in what Pam says about us over-medicalising it, and actually these are societal issues that we're just not supporting people with.
Yeah, absolutely, and I think my not only anecdotally, but also it's borne out by the evidence. So some of the things that you were referencing earlier, Patricia, around health economics evaluations, that was something we specifically did in Dorset, and worked in partnership with York Health Economics Consortium to understand actually what is the impact of the work that we do, and what is the total effect size of, say, the intervention, as opposed to some of the main factors that impact on somebody's life. And certainly as a therapist, I'd often find somebody saying, well, look, I've got a housing problem, I mean, you can do as much CBT as you like about not being distressed about having a housing problem, but the old adage, it's not paranoia if they're out to get you. And so there are a number of challenges that are really important to attend to in that context. So totally agree. In terms of the JSNA, or the Joint Strategic Needs Analysis, our kind of prevalence within Dorset is correlated with the national figures. So it is worth saying that, for example, depression, common mental health problems show a distinct correlation. The other thing to add is, and when I use the term SMI, severe mental illness presentations are also correlated. What's interesting is that we often talk about suicide in the same breath as we talk about mental illness, and there is an uncomfortable relationship societally that we have around the idea of somebody dying and choosing to die, and the nature of depression, for example. Now, there is an assumption that's being made there when we look at those figures. The fact is that 66% of people who do die by suicide are not known to mental health services. And if you look at the factors that lead to death, it's not necessarily in the context of what might be called a mental disorder. However, what's important is when we think about what's our conception of what it means to live a good life. So again, when we talk about and I will talk about access wellbeing, for example, and our broader community mental health transformation, what is our relationship with people when they self-identify a problem or crisis, as opposed to a disorder per se? And I think it's a really important shift in language. Trisha.
I love you. You're speaking my language. Question for me: when we was at the when we hosted the Coastal Navigators event a few days ago, in one of the groups we were talking about some work that had been done in another part of the country on suicide prevention. And my thinking around that work was, we're over-medicalising this and turn it into a medical problem, when in reality, if we looked at the root causes, they probably won't be medical at all. They'll be societal circumstance, deprivation. Do you think that's one of the issues that we've got nationally, that we can focus on something assuming it's a clinical issue without really thinking through? Because I'm thinking through also what our neighbourhood teams do when we advance into place and the wider determinants. How do we really get these things right, rather than doing what we've always done and then missing the point?
Absolutely. We try and hit a target and miss a point. Is often the issue, and part of this is about our route to people don't like it when I say this, but our commitment to our own self-destruction, ultimately, that movement, that leftward shift, that input of resource into society and communities, it's a terrible thing that we exist as health services. We shouldn't need to exist because actually we are meeting a deficit per se. Now we do know that tertiary prevention strategies for suicide are actually quite effective, and people are highly unlikely to attempt again if those tertiary prevention methods are in place. We also know that there's a high correlation with the use of substances to reduce that reduce the barriers to harming oneself. So when we think about mechanistically some of the things that are going on, is the answer having a mental health professional involved in going to reduce somebody's likelihood of harming themselves? We also know the positive predictive value of any suicide prevention measure is much less than flipping a coin. So it's about 10%. Yeah.
Cover this. This is very personal to me. I can probably say it without blubbing. I lost a brother to suicide. And actually, he was very much at the tertiary end. He spent 9 months. And East London were fantastic. East London Trust were brilliant, and the quality of the care he got. But he did make multiple attempts. I guess what I wanted to ask you is, long before it became medicalised, we didn't notice the warning signs, not his family, his workplace, or anybody. And so, how do you prevent getting to that later, very serious stage? Because probably we could have prevented it somehow earlier on, but you may cover that around. But
it's very difficult to answer the question directly because the implication is around the responsibility and where it sits.
Yeah.
So what I would suggest is I would talk a bit about access wellbeing. I'll talk a bit around how our mental health services are delivering services. And our overall plans, and perhaps if we try and fulfill your needs at the end, with, if I may. Yeah, no, but the curiosity around it.
Or diabetes, even if it is their specialty, how do we raise awareness?
Indeed, and that's linked to a network issue. So I'll highlight that a bit later, if I may. I'm also mindful I'm probably quite behind time, aren't I? So the other thing just to know is that there isn't a firm figure, and I'm using the term personality disorder advisedly. So the term personality disorder, you may have heard that term before. It is something that is an egosyntonic presentation that's quite pervasive and goes across different areas. That doesn't mean much. What it really means is it's where somebody experiences or causes distress as a function of the way that they live and experience the world on a day-to-day basis. And you'll note that I've put it just before I talk about autism and ADHD, because again, that is another type of presentation, and it's not a mental health presentation, but it's a neurodiverse presentation where people experience difficulty in living their lives within the society that we operate in. And it is important to note that all of these things are a function of the definition of society. So all of these things have moved in the 100 years or so since they were invented, and they will continue to move as our society changes. And so sometimes when we have the question of why has the rate gone up, we don't ask the question of how has society changed. And it's an important thing for us to know in terms of how we frame and structure the way that we live our lives in society. I'm going to move on because I'm mindful of time. Now, I've already alluded to no health without mental health, and particularly there was a movement to being more outcomes focused. I'm not going to read the really small slides, despite I appreciate your short-sightedness, but then to be honest, I can only just read it from here. So I'll move on, and I know you've all had the slides, so I'll take them as read. One of the things that was important, though, is that we moved on to then, and it moved on to the 5-year forward view for mental health, which then culminated in the long-term plan. And there were particular areas that were focused upon. Talking therapies, or IAPT, in improving access to psychological therapies, was one of those areas that was celebrated, partly because it gave a very clear output. You could, it could be modelled to within an inch of its life, and it provided a very clear metric for recovery. And also it was built on an economic argument of, if this many people are not depressed or anxious, they are able to be economically active. And therefore there is a treasury argument as to why we might fund this kind of service. Now that's a predecessor to how we might then think about how outcome-based commissioning might be relevant, and what the Dorset pound really looks like. And it's not necessarily to say that is the answer, but it is worth saying that when we're thinking about conceptualizing mental health outputs, how that could be understood, but again, for us not to miss the point, because a target isn't necessarily the crystallization of the totality of what people might be experiencing. So the other areas are around perinatal, early interventions for psychosis, individual placement support. Now, I'm mindful I'm just kind of skipping through these, partly because I'd like to talk about the experiences of people. Dementia diagnosis, contact numbers, eating disorders, and out-of-area placements, which are in the context of mental health units. I'll talk about those figures in a moment. And the performance for the local area against those. What it's worth saying is those all had an increasing trajectory, and some of those were impacted, of course, as all things were, by COVID. And they interact in different ways across the larger transformations, say, for example, the children, young people and families, mental health transformation, and the adult.
I mean, very timely, because I was just going to sort of come in there, Morad, because, and for the people who know me well will know that this is one of the bees in my bonnet, being a neonatologist by background. But one of the things that I sort of feel that we really don't have a grasp on at the moment, fits in very much with our children's strategies, is that we know that one of the biggest predictors of children being anxious or depressed in their teenage years is having a mother who was anxious and depressed in pregnancy.
Yes.
And I'm not sure that we've really ever got a grip in that. Now, that is not going to be a medical problem to fix. That is the societal problem, because it will be absolutely linked with all the things you have said. But I always sort of feel that I'm slightly derelict if I don't just remind us of that point, because it's because if we're going to make an impact into those long-term life chances, those long-term life health plans, actually we're really going to have to start bringing it right back to even before the point that people are currently being born.
Yeah, indeed, and you know there's an economic argument there as well. You know, we're talking about the impacts are wide-reaching for any network there, and as we say, it takes a village to raise a child, but also, you know, you have to think about who's in the village and who populates it. And whilst we might have prioritization for those people who are within the neonatal period, it doesn't mean that's the totality of the answer. And so I would also say, though, the Southwest are performing really, really well when it comes to the maternal mental health strategy. And I'd say it's actually really positive to see some of the things that have changed over recent years in working together across our different spaces. But again, I agree. I think there's more. I'm going to move forward a slide, if I may. This is just to reference funding, essentially to understand that we do have something called the MHIS, the Mental Health Investment Standard. This is historically a ring-fenced budget in of itself, and the idea is that investment is increased above non-mental health services, and it was linked to the concept of parity of esteem. In terms of the way that it works in reality, is the Mental Health Investment Standard expands at a third of the rate of our what's called SDF, or Service Development Transformation Funds. I'm teaching people to suck eggs here, but it is worth noting that there are a number of services that have developed within the context of SDF funding, and we've had to try and figure out, particularly this year, how we continue to sustain those services, but then also work with transformation. And I think that there are a number of things that we really need to just kind of bottom out and think about in terms of what our delivery looks like, and noting, you know, the future of mental health in of itself and our health systems, and where mental health sits within the context of our health systems. I think the other thing I just want to highlight is the MHIS has always been explicitly around mental health, as opposed to learning disabilities and autism, but often they are talked about in the same context. I think it's important to recognise there are differences. Okay, if we move forward a slide. So talk about services in Dorset. For example, Dorset Healthcare has 3,000 staff focused on mental health, children, and people, families, mental health, so within my explicit directorate. And there are a whole suite of things. I know we've talked about tertiary, secondary, and primary, but we have a number of provider collaboratives, for example, forensic, perinatal, eating disorders, tier 4 CAMS, etc. So a number of services that are being delivered at provider collaborative level across different regions. So whether you're thinking about the Southwest looking, or whether we're looking at Oxford, or whether we're looking at Hampshire, or whether we're looking at Dorset, there are a number of provider collaboratives. We have high acuity inpatient community services. I would say a lot of attention goes on those services as opposed to where the greatest impact occurs, which is in the community. Over half the mental health activity, for example, happens in our NHS Talking Therapies service. But whilst there may be reporting numbers against that, they're not necessarily seen as high profile, but that's where a lot of the work does occur. Access Wellbeing, and which is the broader totality of the community mental health structure now, a lot of the work is going on there as well. But again, the attention and focus is often on those high profile, high harm, high consequence services, and as such that can sometimes challenge us, because often what we're doing is we're focusing on the wrong bit of the plane, so that then we can provide much greater improvements.
No, I'm just interested in terms of, because you've been with community service, general community services for some time.
Yeah.
Have you actually integrated more of the mental health expertise into the sort of more mainstreamed community services, or not? Is it still quite siloed?
So it varies is the answer. So the nature of certain neighbourhoods have different levels of maturity. The integrated neighbourhood teams gives a mandate to how that may be structured. I know we've made a number of attempts over years to work with different structures, and obviously the introduction of primary care networks means that we were able to have ours workers, additional roles, responsibilities, workers where we would work jointly with our primary care colleagues, but also we have integrated functions with our local authority. And I guess what I really want to be clear about is our biggest relationships are in those spaces often, and that's where we have the biggest impacts. So the answer is yes, in some ways, but not completely. It's not one picture, I think is the answer. I'm aware that there are. I'm not going to carry on talking about these services. I'm sure that if you want to ask questions, I'm happy to bring those up at the end, because I think we're probably running out of time. And again, I'd like to make time for the user experiences. Yes. Yeah. Okay.
But if we ideally,
sure.
Wrap up by 11:30, 15 minutes. But
okay.
We have got a bit of leeway because
okay, wonderful. However, I'm also mindful that there are questions, and I'd much rather be talking to people. Nature of being a therapist. Okay, shall we move forward to the next item? So one of the parts of the brief was to just kind of talk about our relationship with the third sector as well. And it's worth saying that Dorset Healthcare, and I came from another NHS trust, and I was really struck by how good the relationship was with Dorset Healthcare when I came into the system, and particularly the representation of lived experience and genuine lived experience and co-production when I came here. Now, it's slower and takes more time, but the outcomes in of themselves are perpetuated and more ingrained, and so one of those things was through the WARP, so the Wellness and Recovery Partnership, which is the partnership that Dorset Healthcare has with Dorset Mental Health Forum, and how that's grown. The Dorset Mental Health Partnership, which includes a number of providers that Dorset Healthcare are commissioning, has particularly looked at how we can grow to be more collaborative. And one of the things, particularly over the years, and particularly with the way the VCS Assembly has developed, we particularly looked at, well, what is our service delivery, and how can that be more effectively delivered into the community? And that includes, for example, the grants functions, the community mental health transformation program, so DCF, essentially working to help grassroots activity within mental health spaces, so that communities can grow and can thrive, but also in nearly every program that we've had, which is transformative, since I've been here, it has included resource with our voluntary community services, and it's been a really interesting journey, because it's very different to a classic commissioner-provider relationship of days of old, and the nature of collaboration has been really representing the principles that we'd want to eschew with the people that we serve as well. So we have a number of services that we do deliver. The Access Mental Health structure, which is about our high acuity piece. So those people who have self-defined distress and access particular spaces like the retreats, like the community front rooms, comes around the companies linked to the mental health clinical services review, and it's been a real success if we were to look at the data and the way that has shifted some of the activity that we may have classically seen in other spaces where people would present. Obviously, that continues to develop, and we're working to improve that, because one of the other things is Access Wellbeing is launched in the last year, and that's been the subcontracts for Universal. So the Universal services have gone to our VCS colleagues, and BCHA lead that, and have subcontracted to a number of partners, and it's been a real learning curve for us. So the forgiveness, not permission mantra that I often eschew has come back to hit me in the face a few times, but I think we've really seen the benefits in terms of our communities and in terms of what's delivering. So, for example, next week there are a number of things going on in our VCS spaces where we have a number of events that are engaging with the community, and it was really nice to see that crystallise last week. I attended with Tanya Whittle, and we got to see firsthand the way the communities are being built, the way that people are engaging with new things and giving back to community. Because the other thing is that this creates things that cannot necessarily, what could be monetized, but would be too expensive for us to monetize. And so the relationship with the third sector is really important, but also not the totality of the answer, because of course we need to be able to sustain our third sector colleagues as well, given the challenging environment. I'll move on to the next slide, please. Right, okay. So system priorities have already been referenced. I would highlight that in terms of the big five for our joint forward plan, we know that improving the lives of 100,000 people impacted by mental health are part of that. We also know that the life expectancy gap is improved by the delivery of these services, and there's a high correlation between those people who have long-term conditions and engage in mental health treatments. There's quite significant recovery attached there, because often 66% of people with those conditions do tend to have a mental health problem, understandably. And that correlates with life years. Next slide, please. There are plans to prioritise a number of these things over the course of next year for the Mental Health Delivery Board. The prioritisation is contingent on confirmation of some of our financial profile. So as it stands, there is a refinement of the forward plan in June once we do have that confirmation, but these are the things that are on the list this year, and they correlate with the operating plan. Next. You did. Right. I think I'd like to skip forward to the videos then, please, if I may, unless there are any questions up to the point that we hit that slide. No? Okay, so I guess what I'd like to do is just introduce some service user stories, and I'd like to start with Louise's story, if that's okay. And I'm sorry about all the
I think what the beauty of
difficulty
access
doing
wellbeing is that it's completely holistic. It's very person-centered.
Sorry, that's Cassie.
And it's really thinking about what.
Growing up, I had times where I felt so down and had thoughts that I didn't want to be alive anymore. I tried to tell adults that I was struggling and that I wanted help. Some didn't know how to get me help, and others said that they didn't want to hear any more of it. I felt alone, like I was being dramatic and that my feelings weren't real. By not being taken seriously, I developed a low self-esteem, and I believed that any feelings I had were something that I had to hide and ignore. In my mid-20s, I began to experience shortness of breath, a racing heart, and severe sweating. I began to withdraw from my friends and family, and negative thoughts about myself and what others thought of me were becoming more intense. Sometime later, a family member said that it might be helpful for me to speak to somebody. They suggested that I make a referral to Steps to Wellbeing. I was surprised. I never thought that I was bad enough or that my problems were worthy of a professional's time. Finally, someone listened and my feelings were validated, and I was relieved that they were real. My treatment at Steps to Wellbeing opened the opportunity for me to explore my feelings and find strategies to help me manage my symptoms. The help that I received from the service really helped me to change my life. I spoke about my experiences and everything just began to make more sense, and I really felt that I could start to understand myself better. Of course, I still have moments where I struggle. However, Steps to Wellbeing has really helped me to make changes that I never thought were possible. I would urge anybody who may, for whatever reason, be hesitant to reach out for help to refer themselves to this service.
Louise was able to refer herself and find time to engage in a psychological intervention. And I guess one of the things that might be helpful to note is actually Louise then decided that she wanted to start working for us, and she wanted to do some of this work. So she now works for us as a peer. And this in of itself just kind of represents some of the other effects of the work that we do. And at the moment, obviously, we're sitting some of our community functions here. And obviously, what we're talking about is how does that transfer? So what I would like to do is just kind of move us on to Cassie, if that's okay, and talk about open dialogue.
What it is for them that is they're struggling with. A big aspect as well is I have trained in peer open dialogue. So we try and work with people's networks. So I work on a one-to-one basis, but also we might have network meetings with that person's network, who they choose to be in their network. And what's really important about that is actually it's about building resources and resilience within their network and within the community, so that they don't have to rely on mental health services. And it's about building the strength between them and the community, and whatever that looks like for them, that they need to be able to feel like they can move forward for themselves. So what is good about peer open dialogue is, especially within the within this Dorset area, is the fact that we have different services that have been trained in peer open dialogue, and I think it's really about that fluidity, about being able, so if people are under the community mental health team, that really kind of more fluid transference over to Access Wellbeing. But also if things do spike up again, someone from CMHT or the community mental health team can come back in, and they can, if they're needed to kind of have those conversations instead of having to keep referring back in, etc. So I feel that's where the beauty is, but also it could be their social worker or their GP or their social prescriber that they're also involved in, or their reach worker. They could also be connected into the network meeting, and that has been happening. And what's been wonderful about that is the fact that we all hear the same thing at the same time, instead of having different dialogues at different times. And that's been really powerful for the person of concern, because actually they feel very heard and listened to by the professionals, but it feels that everyone's on the same page to be able to move forward with making kind of like suitable kind of steps towards their care that feel kind of, when we're collaboratively working together, feels more kind of productive.
Sorry, I'm just going to run out of time, so I haven't even enough time to tell the story.
So I'd had some struggles through my life with health, spinal condition.
You'll hear that.
Which tended to get me down a little bit. And I found myself not enjoying life as much as I kind of felt like I should, or that I could see other people doing. And then in 2021, I diagnosed with a pituitary brain tumour, which I found really difficult to cope with. I went and saw my doctor, and I broke down. So I was introduced to a mental health nurse down at Hope House, and the mental health nurse organised changing some medication from one to another. That was at the point that I was introduced to the wellbeing coordinator at Access Wellbeing. I think the first thing that I was finding really difficult was understanding how to communicate. And that is one of the first things that the wellbeing coordinator managed to teach me how to have an awareness of, not just to be able to say words, but to really understand them and feel them. I would say over the next sort of 6 to 8 weeks, it was really kind of finding our feet. We had weekly calls, plus there was some additional support if needed, which was really, really helpful. So that first 6 to 8 weeks were really critical in allowing me to find that voice and start to learn how to heal myself. So the work-life balance was quite a crucial element of my recovery, in that I would work 12 to 15-hour days, 5-6 days a week. I felt that was normal, and I felt that that was right. One analogy that was used was around a bag of pebbles, and if you keep filling them with pebbles, eventually it'll get too heavy and you'll drop it. So effectively, kind of in my mind, it was to empty the bag completely and just put the important ones back. And the minute something went back into my life that wasn't comfortable or didn't feel right, was to immediately move away from it again, go back to the elements that were important or that made me feel better. I think having all of those tools to recognise, give yourself some space and time is really important. I've never enjoyed fitness, and what I actually managed to do was work out that if I go for a walk, I could spend an awful lot of time kind of teaching myself and telling myself that things were actually okay. So quite a lot of the times we'll have a session, and rather than just go home and go back to life, I'd go for a walk. And it allowed me to almost have an additional session, but just to myself. Other tools that I found are communicating with my friends and family. A lot of my friends, excuse the term, but they're manly men, and we just don't talk about our feelings. And I actually started to open up to one of my friends who equally didn't realise that they were struggling. So through me being able to be more positive about my own mental health and being able to share my experience, actually allowed my friend to talk to me. The tools have been more than one or two. You know, they affect every part of my life. They've helped me in every part of my life to cope with difficult situations at home, difficult situations at work, even difficult situations sat in a traffic with someone beeping their horn, and you're just thinking, actually, you know what, someone's probably having a worse day than I am. But I think for me personally, it's given me the tools to look at myself and be honest and open with myself. And then I can be open and honest with my family and my friends. It's truly given me a space to be able to check in and put the right mechanisms in place that are for me, that help me every single day. And in doing so, I can be a better person to help others. It's not just given me back my life, it's given me back a far better quality of life, a better quality of family life. I would say that it's given my daughter her dad back, and I would say that it's given my wife her husband back. Access to wellbeing has absolutely changed my life, and it's not just changed my life in the short term, it's changed my life for my life.
See, we're at time, so it's difficult to have any more questions.
But we actually, and we should do it again, and it's quite relevant for the ICB as well, around how in our community we deal with some of the issues that you spoke about earlier. So in itself, we're really welcome having this, and we should think about doing it in order to check that we think that things we're working on are having impact, or do we try other things. But I'm happy to give a bit more time if anybody has any questions, and then I'll give you the opportunity, right, just to say anything else. Did anyone have a question?
It's not really a question. Well,
it's a comment.
It's a comment that first, I visited the Access and Wellbeing Centres. I think they're fantastic. I was converted within the first 10 minutes because they get underneath the social causes of mental health, and so you're into a different stratosphere, aren't you? And they get to the heart of what place is really about, because most of the people that came through that door had housing issues, employment issues, a whole range of issues, actually, that once they were resolved, they were able to contribute to society again. So there's something about us being really clear about what the root causes of illness is, and not always jumping to a medical or clinical solution that might not be the answer. But actually, what's more important for me in this is it gets to the heart of what the feedback was from the community when we put the ICP strategy together. Please create networks. Please help us create a sense of belonging. Invest in the third sector, because that's where we go first when we feel unwell or recovering from ill health. It was all that stuff that actually has got nothing to do with the NHS. It was, how do we create thriving communities so that we can contribute and live long, healthy lives? So this is really important. And I think there's the next phase, I think, is trying to work through how we're able to evidence, not how many people use it, but actually how effective it is. What's the outcome? Because then we can really start to show that what this does is reduce demand, and what it does is create thriving communities. And it's all the things that we should be doing as part of what will be the 10-year plan coming forward in the devolution agenda.
Thank you. Nick.
Thanks, Rob. I just wanted to thank Morad. I think I always learn a huge amount when I listen to him. I think he's a great advocate for mental health in Dorset. I think he makes things better, and I know he works tirelessly to do that. So thank you, Morad. The point I was going to make, maybe similar to Patricia's, is I came from an acute background, but as I've moved into the joint role across the DCH-DHC Federation, one of the things I've been really struck by is that the philosophy and the approach within that sort of mental health space are ones that we absolutely need to adopt in our wider transformation. So a huge amount of lessons from the access wellbeing transformation going into the integrated neighbourhood teams, picking up Siobhan's point about actually really thinking about how we bring those community mental health elements together, and I think there's huge opportunity there. So when I think about universalism, that philosophy around meeting people's needs, the co-design, co-production, how we work with VCSE engagement, I think that's all there, and we really need to kind of adopt that and learn from it. And then I guess the final point I was just going to make is that, we all know there are really tough times ahead, and there are some sort of difficult decisions to make, but I would I would just say we all kind of need to keep, I guess, the sort of the passion and also the rationality that Morad's talked to us about today and shown today around kind of the approach to mental health and what difference it can make at the forefront of our minds as we're going through the kind of the coming months. And I would include our kind of decisions around the CYP mental health transformation within that point as well. But Morad, thank you.
Yeah, thanks very much. Morad, is there anything else you hoped would come out of today that you wanted to say? Oh, Siobhan, Siobhan first. I'll give the final minute to you.
Sorry, Morad. But I really, what you've described, it was brilliant, and I've really loved it, and the ethos. But I suppose what's also running through my head, and it's a longer conversation maybe outside, but actually, what about those people that don't engage? Yes. Where the risk is, there's just something for me that wasn't in that. Which just worries me, because I think this model is very predicated on people who do or will engage, yes. But actually most of the risk, where you see from elsewhere as well, is in those that don't.
Absolutely. So I have a much longer conversation around this as well, Sean. You might have some insight after Mark's presentation later as well around the intensive and assertive components of our services, because you're absolutely right. It's the unengaged customer that we also have to think about, as opposed to those people who are willing to come through a door. And yes, it's all well and good also having, and I would also add, having a nice shiny hub for people to attend. However, there's the virtual piece, which is really important, because, for example, I've reflected, and I don't know if I'd walk through the door, for example. So we also need to cater for the other parts of our population. That was really important in the feedback that was provided when we were creating these things. And I guess that kind of links to the question you were asking earlier around actually what needed to be happening earlier, and I hope what you have heard is there are things that are happening that do occur much earlier, that where we are able to address some of the challenges that people do face, and so it is something about being able to have that empowerment and ability to change some of the things around your life, as opposed to when perhaps it may be a bit too late and we're dependent on high intensity services that unfortunately are then the control mechanism, as opposed to the individuals being able to make those choices and changes. I'll stop there. Thank you. Thank you.
Thank you, colleagues. So this is the board assurance framework. It's been through all the subcommittees, and colleagues and leads for the risks may wish to add comments or respond to any questions you might have. Just a point I wanted to make more generally, it's in the paper, but just to sort of reconnect the board with the work we had intended to do around improving the board assurance framework. We have been looking at this since the autumn last year, October, November time. And we started exploring how other ICBs were doing their board assurance framework. We worked with our auditors, BDO, to try and review and find best practice. And we had and so we've made some adjustments to the board assurance framework that you've got in front of you. But the main thing we needed to do was take some time out as a board and reset the board assurance framework against our agreed strategic priorities for this coming year. All that preceding the announcements that followed around the change in organisational form for ICBs, which kind of sort of takes out the momentum that we needed for setting strategic objectives. Now, of course, we do need to have some strategic ambitions and goals we go for that we are aiming to deliver through the course of this remaining year. But the actual longer term overarching strategic objectives will be set by the new organisational identity, the new reformed, recalibrated ICB. And there was a danger that we would end up trying to redo our board assurance framework with these interim objectives, and then have to do it all over again once the new organisational form came into being. So the agreement and the implicit agreement has been that we will maintain the current board assurance framework pending the developments and announcements and confirmations of what the ICB should be, and we'll fold it into the new organisational form as it comes into being, because there will be new strategic priorities or orders of strategic priorities set as part of that. So what you've got in front of you is a kind of constantly under improvement and finessing, but not the radical change that we were hoping or expecting to have to do at this stage. We have put that through each of the subcommittees just to check and challenge that, and it's been sort of endorsed through that, but it's here at the board just to keep an eye on the risks and the strategic risks that are in there that we're tracking, which is still relevant because they're important parts and dimensions of the work that we're responsible for, but also recognising that that bigger change that we wanted to make will be rolled over into the new organisational form.
Yeah, thank you very much. They're very relevant. They're the job. Any questions? Yes.
Just to comment, we did give this a good old outing at Risk and Audit Committee and were supportive of the recommendation here not to do further development work, but also had a number of requests that we do double down on what's on the page, less so much the subheadings, more the mitigating actions, because these risks remain relevant and real, and therefore the mitigating actions just need to be prosecuted. Yeah.
So exactly as Adrian just said, really, we do have a few of the risks that are outside our tolerance level that we set when we established the priorities and the strategic objectives we wanted to pursue. Within all of these, we are continuing to work and chip away at the various things we need to do to bring those within tolerance and indeed sort of mitigate the risks altogether. I think there's more work going on than appears in the board assurance framework because people are trying to be concise because it's quite a lengthy, complex document. So I think we're taking those actions away. So those, I'm sort of responsible for a couple of those. And our colleagues, exec colleagues, are taking that work out and we'll bring it back in the next iteration. So I think all the risks need to be kept an eye on and improved all the way, but the ones outside tolerance, it might not be possible within the time we have as Dorset ICB to completely close those down, but we need to continue to improve them, and that's the commitment that we've made. So I would say just those are the four main areas.
Thank you, Graham.
I think just the one to flag for me is digital maturity and just the current focus on cybersecurity in particular. Yeah. You know, the number of attacks every organisation is getting all the time, the vulnerability we have as a result of the actions of individuals clicking on the wrong things, and you know, just seeing what's happened at M&S and but their public dealing with that has kept it very low profile. Actually, it's been a huge impact on the business. You know, they've lost 4% of share value, I think it was, as a result. So just to flag that one, really, because that one is outside of tolerance and it's probably the most current risk that all of us, I was going to say any of us, it is all of us are facing.
I just obviously was going to flag productivity and value for money because it just jumped out at me, really. And just when I read some of the detail, I thought, I'm not sure that's as up to date as we currently are. So I just would flag that one. And then finally, just the point around all the change, and because I think, do we not in the BAF have to be realistic that that is going to impact over the next 6 or 12 months and is a risk to our delivery of strategic objectives? And you either do that as a separate risk on the BAF or you write it across the risks that you've got in the BAF. And I suppose I just think it's probably very important that we do acknowledge that because it's a difficult year.
Well, just to confirm that was very precisely the conversation we had at Risk and Audit Committee, because the idea of it getting rid of every individual risk, A, it would just be wasteful, and B, you'd lose focus on it. So we resolved that we should be bringing forward one overarching additional risk, which is the management through change.
Cool.
Thank you, Rob. And just to build on the change risk that Siobhan and Adrian highlight, whilst the current workforce and culture risk on the BAF is showing within tolerance, I do want to highlight to the board that the productivity, performance and value is outside tolerance, and the two are intrinsically linked. And there are two rising risks on the corporate risk register, which will feed into this. And yes, I'm agreeing that we need to look at a BAF risk around change, because there are two rising risks on the corporate risk register. One is around the current financial context, the impact that has on workforce engagement and morale and ability to continue to deliver. Also, the impact that the constraints that we're working on have on future workforce supply, our ability to hold our commitment to education and training capacity, and our ability to grow further future workforce supply through apprenticeships. So there's that strand of the workforce and culture risk, and then there's also the change strand and the impact that the current context has on people's ability to focus on delivery. So that work in developing those corporate risks is something that we'll talk about in part 2 when we get onto the corporate risk register.
Thank you very much, Dawn. Just to highlight some of those points that were made, Graham, I guess on cyber, the joint appointment of Beverly for the NHS side as a joint Chief Digital Officer should give us renewed attention to our shared capabilities, and that's probably worth noting. Siobhan, on productivity, what would you highlight as the one or two things that are going to happen next to try and better mitigate what you pointed out is a risk?
There were two areas which said TBC, which always makes me slightly anxious. So I thought actually they definitely need filling in. But actually, you know, everything is sort of interlinked, and the productivity side, it links to workforce. I mean, there's a really interesting sort of combination there, and I'm not sure. When I read this, I just thought I wasn't sure that came out.
Well, maybe when we do the performance report later, let's focus on how we're going to achieve our WTE, because that probably is a risk for us. The one that I would have highlighted here is probably the importance of health inequality, and making sure that during this transition we don't lose sight, and sort of ask a lot of questions at the board here to make sure that we keep interventions in place to try and deal with our health inequalities. And again, David, if we were going to do one or two things to try and get within tolerance while we've got the ability, what would you say comes next for us?
That's the work that we're currently doing, and we've got conversations later on in part 2 where we'll be talking about what happens next with the transition. I think there's a careful balance of so Dawn talks about the kind of the actual physical numbers, but there's also the capacity of individuals to focus on this and bring people with us while we're trying to make big changes happen. So, for example, in the social mobility one, which is really, really vital to tackling inequalities, it's part of how we unlock improvement and economic growth, which is much broader than health, of course. In the BAF, when we originally crafted that, we had two main things we wanted to do. One, launch a campaign to raise awareness about the opportunities that exist, because a number of our organisations and partners and private industry, private business are running social mobility initiatives which people don't necessarily know about. So that's one thing. And the other was to bring and build a conference to bring those ideas together to see if we can make them happen. And we were going to sort of try and convene that as the ICB. That's going to be really difficult for us to do when we're trying to deliver a really challenging financial and delivery performance plan and deal with the massive change that's coming down the line. So the question for us has been, what can we do in lieu of that while these changes are taking place, and still hold it as an ambition. And there's loads of stuff going on, which we've heard about already, about the Customer Navigators Network and the apprenticeships and so on, which we're working really hard to address, which will achieve some of the same ends without quite the big impact that we were hoping to get. So that's the refresh and review work that's underway currently.
Thank you. Look, typical Ned thing to say, so don't get too cross with me. It's sort of important, isn't it, that there will be things we can't do because of these changes which are taking place, and it's right that we have a line. On the other hand, the things we can't do probably shouldn't be our strategic risks that are outside of tolerance, and it may be that we have to let some other things go instead. So I think the attraction of having a line rather than it permeating into every area is that we have a discussion about what won't be possible now, and it might not be that. Yeah, you know, and actually we might say, do you know what, we absolutely have to do this piece of work on social mobility and health inequalities, and it's something else that we'll let give. So if that's all right, we'll treat it that way. Patricia, we finished 5 minutes early for a break, so can we be back, please? I don't see any other hands up. No? Cut anyone across? Thanks very much. That was very helpful, and I think we agree with your proposal that we stick with the existing BAF rather than develop something new. If everyone's happy with the recommendation, we got 10 minutes for a break, so we're running 5 minutes early. We'll be back at 12 o'clock rather than 5 past. Thank you very much. item 6, the performance items. We have some folk here. Dawn is due to address one of the escalation feedback, but somebody else can cover. Yeah, thanks very much, Pam. So, and obviously there are different performance issues can go across several issues. So if you've got a performance issue to raise from the totality of what we see in all the performance reports, I suppose raise it at any time is my advice, rather than wait for what you think might be the right one. So should we start off with Kay? I think you're going to give us feedback on SOC and POP as well. Kay.
Yeah, thank you, Rob. We welcome the reports from our partners in Health Innovation Wessex and Wessex Health Partners, and both their reports and their plans for the future are absolutely in line with both our priorities and the government's priorities. And this is a very good example of us working in partnership to actually drive things forward. And it looks as if there's going to be some extra funding to continue the work, or has been agreed funding to continue the work through the Accelerating Innovation System Health Service Foundation. There are 3 key clinical areas that the committee has been monitoring in terms of our future work. One is in respiratory, the other CVD, and the third is ageing well. Now, both respiratory and CVD have reported before, both to the committee and to the board, but ageing well has been slightly slower to get moving. They highlight at this time the work's been done in Weymouth and Portland with regard to the preventing falls subgroup, and in particular the impact of the management of exercise pilot there, which has shown really good outcomes, and it would be good if that could be extended elsewhere if the funding could be found. With regard to risk, the risk on the electronic health record had reduced because it was meeting its timeframes, but it's important that we do continue to move forward and develop a comprehensive digital strategy for the system, because that's still something that's on the agenda but not yet completed. Any questions? Anything anybody wants to raise?
Anyone? So can we note the report, please? Thank you very much. Next one.
I think that's still me, isn't it? Because it's the prevention, the policy committee. We discussed a presentation on the variation in health inequalities comparing Dorset to the national. It'll need further analysis and work, but there are some issues there that are important to actually look at in more detail. And the committee did ask for an evaluation of the programmes that we have been running and any changes in the last 3 years since the ICB has been established, to see where we are with regard to health inequalities. We had a presentation on the integrated neighbourhood teams, and we're awaiting some further issues on funding, although I gather that may or may not be used in the integrated neighbourhood teams. The oral health programme update was very interesting. There have been some successes there. For example, the Health Sciences University is being commissioned to establish an oral health institute, so that's a vehicle to design and deliver future workforce model that will support this. And obviously the fact that we have no dental college in Dorset does make it a little more difficult. However, on some areas there has been less progress, such as the supervised teeth brushing. That's very variable, and access to NHS dentists remains problematic. So work is continuing to try and push this nationally and see what can be done about dental contracts. We received the Better Care Fund plans, which have been approved or accepted by the Health and Wellbeing Boards. I think we'd like to, in future, see some evaluation of the impact of the funding going forward. On the risk issues, the only thing we highlighted was that we felt that there needed, and this was said in both committees, that there needed to be some recognition of the issues around reorganisation, but that's already been discussed earlier.
Thank you very much. Any Any questions? So I think, Pam, you're going to cover people, are you?
Thank you. So just wanted to highlight a few things really. We had a deep dive into the nursing midwifery workforce, which I think was really helpful, where we can see areas where we're actually almost oversubscribed, and then areas where there is deficit going forward. And some of the work that's happening both locally across Dorset, but actually across the Southwest region as well. And the recognition of a more digitally enabled workforce needed going forward. Two key areas really to draw out as well, and Dawn would want me to draw out, is for the next 6 months or so, the focus really will be on the delivering of the operating plan in terms of the workforce reduction, and also obviously the transition through change as well, which are both highlighted and have been previously discussed as well. So again, I was happy to go to questions if there was anything particular.
Well, can I ask about workforce numbers? It's one of the issues in the performance report later on, so I suggest, you know, raise them now. Or it does look like a real risk for us, doesn't it? And it will have quite a big impact on our recurrent SIPs if we don't get this right. So I think I wanted to ask, what else do we need to do rather than steady state of what we're doing? And is there a piece of deep dive work involving execs, and I think probably a bit of governance oversight on that through the committees or a working group or so? But my sense is we're not going to hit our workforce targets to generate the recurrent SIPs that we need. Is that right, the way that I read the reports, and what do we do? Jenny, do you have any thoughts on this as well? Am I right that we might not be on target to hit our recurrent SIPs and workforce implications?
I think providers have been working really hard, and Siobhan would say the same. Providers have been working really hard on their workforce plans and making sure that they triangulate to their finance plans. What we're still seeing is that there are workforce assumptions that don't quite tie up to the finance, and that's what we're working through. I think that's fair to say, isn't it, Siobhan? And there's also an element of efficiencies yet that aren't identified. So by its very nature, there's roughly 30 million yet that isn't identified in providers. That's going to have to be some workforce as well, and that's not yet identified and reflected in plans. So there is an awful lot of work going on behind the scenes to make sure that we are getting to the point where we can absolutely say this is how many workforce will deliver that. We've been having some great support as well from Simon Fuller from NHS England, who's been working on not only what the workforce plans are, but the phasing and how that will lead to the savings in year, and how the numbers don't necessarily correlate to that full year effect, and then looking at what that gap that might be and how we close that gap. So lots of work going on in that space, some of it still to be concluded.
Thank you very much. I'm going to bring Siobhan and then you, if that's all right, Siobhan.
Yeah, just to add, you said steady state, so I'd probably challenge that, Rob. It does not feel like steady state at all. And actually, the financial challenge this year for all of us is bigger than we've ever faced. So, you know, within the trust, and Nick might want to come in as well, our savings plans are just under 8%. And for us at UHD, that means we're saving £62 million as a target this year. 45 million is currently identified, and that is work that's ongoing, but that will be the largest CIP that we would ever have delivered in the history of the organisation. So we're still working with the care groups. I actually feel the triangulation around the workforce and the CIP is probably better than we've had before. But we still have work to do to absolutely identify the specific number of posts linked to care group CIP plans. But actually, this is more radical and deeper than we've ever delivered or planned to deliver.
No, thank you. And you're right, steady state is not the right term. I think I was trying to be polite and instead use the wrong term. I don't think we're going to, the way the numbers look to me is we won't save all the posts that we need to in a recurrent way. And that's what I'm trying to say. And so I used the politeness of the activity that we're doing to try and save posts looks as if it's going to hit a number that isn't the number we need to hit. So you're right. I'm not suggesting it's steady state. There's a huge amount of work going in. Are we going to miss the target of the number of posts we need to take out as a system recurrently? You go.
We've got to take out just short of 1,300 posts, and so far we've got a plan that delivers half of that, as in the financial worth of it in this year. So the challenge is we've got to get to a place where we're delivering more of that this year on a recurrent basis, and that means we need to shunt up the phasing of our workforce reduction plan, because otherwise we're getting into half of it delivered in 26-27, which means we're not reducing the exit run rate fast enough. So that's where we are, and we've got to move on that at pace.
So I'll ask what we do about that in a moment, but Adrian.
Yeah, how much of that conversation you want to continue in this part of the meeting versus potentially in part two. But I think there is a good and rich conversation for us to have around implementation planning in the round, because notwithstanding the challenges, I think actually there's a good chat to have about the things that need to be true to deliver the efficiency before you start capturing the benefit, whether that's in contracts retired or people, let go.
So first of all, it's a good challenge to me as chair. I have a fairly high tolerance about what can be discussed in part one. I come from a local government background where we are quite careful that things only go into part two, because they are confidential in terms of contract or people. But I think we are public organisations dealing with public money, and if you think I get that wrong, suddenly we need to go to part two, tell me. But on the whole, by NHS chair standards, I have a fairly high tolerance for things being aired in public. David.
Thank you. Thanks for that, Adrian, as well. It's super helpful. I think the challenges that we have, it is on the agenda for part two, and it's an emerging picture. So it's better to understand what the sort of overall plan will be, because then we can sort of manage that discussion with our staff and with our public. So I think in this case, because we're part way through. But I did want to sort of make it so in sort of you're absolutely right that this is one of our biggest risk areas around workforce. A couple of others which we'll discuss later on, and we have to pay attention to it. So that's definitely at the front of our brains, and we need to figure it out. To give you some reassurance, the first thing is, do you know what your problems are, where your risks are? Yes, we do. Are you doing something about it? Yes, we are. When will you have done that something about it, and what will what will the impact be? And there's work going on right now, as Jenny alluded to. And next week, there's a sequence of meetings between the 13th and 16th of May, so Wednesday to Friday. And on Friday, a lock-in of CPOs and CFOs to figure out what all that means. So it's the phasing, the numbers, what's the risk, what's the gap, and what you're going to do about the gap. We'll have an output from that work at the end of next week, and then we'll know the full picture. Regards to, does it meet the total requirement, and or how much risk is required is sort of inherent in the plan to get us to that thing in the first place. So I think if we do that work, and then we can have the discussion probably through the committee initially, to bring it here into board about the full scale of that change and the impact of that, and whether we feel confident in the plans.
That's really helpful. Thank you very much. So just to close off now, I think perhaps, as a board, we can escalate to you and Siobhan and to Nick or Matthew that we think this is a key risk, and can the chief executives have some oversight of that work? And also, it would be a good idea for that to come back to committee governance to look at the detail of that. And if that doesn't quite fit into people or performance finance committee, then maybe a joint committee, or we can work that out what to do. But for now, we would like some chief executive and some ICB governance oversight, because clearly it's a risk. And then in part two, we'll look at some of the detail of that.
Yeah, that's fine, because it will come into our Tuesday afternoon meeting as chief execs, where we're drilling down on the operating plan, were there any risks. I think that we need to keep it in the Finance and Performance Committee, because it's actually about workforce cost reduction, not workforce redesign. So I think we need to keep it there and hold it there in terms of subcommittees.
Thank you. One more committee escalation to come. Is this Quality Quest? Thank you.
Thank you. So you have the report. I think it probably reflects the diversity of subjects and conversation we tend to have at Quest. Just a few things to draw to your attention, though. I think on behalf of the board, we have approved the recommendation for University Hospitals Dorset Maternity Services to exit from the National Maternity Safety Support Programme. I think, you know, there was a real recognition by the committee of the huge amount of work that the team has come in. And also, I think the supported wider partners in that space as well recognised also. We also have a patient story usually linked to something on the agenda. So we had a really insightful and inspiring story around the role local community pharmacists can play in terms of supporting people locally in their communities and actually inviting people into services as such. So that was really well received. A couple of things around, just wanted to draw your attention around MRSA rates. So some of you who've been around a long time will recall this was quite a national feature around 20 years ago. We are starting to see increasing rates again, several drivers, but what we are seeing, one of the main drivers is actually amongst our IV drug user population is one of the bigger drivers. So younger population, I think, than previously as such. So that is one of the biggest drivers, and there is some work happening in that space around that. Also wanted to share that obviously there was a verbal update on the clinical plan, and also just to note that the work, you will recall we were a pilot site for the ICS CQC inspections, and there was some national work taking place around that, and that has now been suspended for at least 12 to 18 months pending the changes that are going to be happening. The Quest reviews the full corporate risk register very much through that quality, experience and safety lens. And it was noted in terms of a new risk that has emerged around access to patient records, particularly through the Dorset Care Record. And that has been escalated through our coroner, actually, through a number of Regulation 28s that we have received as a result of that. And just to highlight that there is new risk management training, which is being well received by staff across the ICB.
Thank you very much. Any questions, anyone? And nothing online. Can I ask then, we don't have any time on the agenda allocated for the supporting documentation on performance, item 9. While we've covered escalations, are there any, sorry. Oh, sorry, go on. No, it's all right. Thank you very much, Adrian.
I understand why you might have wanted to shortcut your way through that.
I've sat through a few audit committees in my career.
I'm reflecting as Pam was talking about the interestingly titled Quest. That if anyone comes to mind, they're going on the rack. So there we go. So from Risk and Audit Committee, it was a fairly standard agenda, but we're in that stage of the annual cycle where we're approving plans for the future 12-month period. So we approved the internal audit plan for 25-26. We asked, and in fact it was already within thinking, that a degree of flexibility is retained within the scheduling, because we can anticipate, given all the transition that's going to be going on over the next 12 months, that we might want some focused pieces of work. So we've agreed that with BDO. We also agreed the anti-crime service annual plan 25-6 in terms of coverage, and there are a couple of follow-up actions which the team are following up on just to make sure that stays joined up. We also approved effectively the management rep to the external auditors, and colleagues around this table should be very grateful that was delegated to RAC, because that was a somewhat painful process, but that's done. We had a look at the award of contracts without competition. There was nothing, I don't think, intrinsically contentious in the ones we looked at, but there was an ask back on the team to try and avoid having any of these, given that we do have examples coming through risk and audit where things had 12 months of lead time and we were still not able to get them contracted through the proper competition. So we were happy to deal with the business in front of us, but we just asked for a bit of attention on that. We looked at a couple of internal audit that are completed, one on workforce controls and one on all age continuing care, both with moderate assurance, and no particular items to highlight or flag here. We then went through the full corporate risk register, and I think members will be familiar that risk and audit is the final committee in the sequence. So we're basically doing the wash up on that. The only thing that we picked up that we just asked for a little bit more work on was calibrating the scores, because when you look across risks on the corporate risk register, it is the kind of, you can understand why each risk individually has been scored as it is. When you look at them across, it's not obvious that some of the things that we've got scoring 20 are actually a lot more clear and present danger than some of the things that we've got scoring 16. So there's some work being carried on that. Otherwise, there was nothing to draw to board's attention from risk and audit, unless there are questions.
Good update. Thank you. Any questions? No one online. And then finally, Dan isn't here.
I'm also pretending to be Dan.
Very good. Good luck.
So I have some righteous indignation about police budgets before we start. So the Business Performance Committee was, again, reasonably standard. We spent time talking about integrated neighbourhood teams, which has already come up in previous discussion. That had been deputed to go back to Productivity Committee by the board. So we were satisfied in committee that all of the follow-on actions that have been asked for have been satisfied, including greater line of sight to cashable benefits, greater line of sight to actually minimum costs required to make good progress. We're still on that point around confirmation of final funding, which I know is being taken forward separately, so I won't dwell on that. I won't read out the other things that are on the page. We did spend a significant amount of the meeting talking about the operating plan progress. We've touched on that previously in this meeting, and there will be more time on that in part 2. So, key points.
Thank you very much. Any questions or comments? Thank you. Good reports back. Thank you. And item 9, while we've sort of been talking about escalations and performance, is there anything from the performance reports that anybody wanted to highlight today? I had a couple of questions, but Dean.
Well, when the reports were written, we hadn't got the year-end position. We have got the year-end position. So if you would like, I've got a kind of a rundown of where we ended the year for the end of March against the performance ones. I can pull out from that the ones that are of concern, if that's okay.
Yes, please.
To do now. So if I start with urgent emergency care, we finished March against the 4-hour standard in A&E at 76%, which was a real improvement from where we were during parts of the winter. So it but that was 2% below what the standard is that we were expected to meet, which was 78%. Just seen really good performance, particularly call out Dorset County A&E department, which achieved over 80% kind of during the year, which is marvellous. And really at UHD, the improvement that you've seen during the year has been really good. So real improvement on that. Bed occupancy, I think probably for the first time in many years, I've seen what we set in our operating plan, we actually achieved for the year, which was 94%. Now that is too high really for how to run a hospital, as you all know, but that was what we set in our operating plan, and that's what we delivered during the year. So that was well done. To support that, we plan to open 250 virtual ward beds. We opened 242 of those during the year, and we had a resourcing plan that got us to 242 during the year. So it wasn't quite the 250, but that's one of the ways that we survived this winter that we'd had. And the utilisation of that, our target was 80%, and during the last 6 months of the year, we achieved 81%. Of the utilisation, and it was quite variable during the winter period, but I think we worked out how to use those virtual ward beds, and that will be part of our resourcing plan for the coming year. If I move on to ambulances, the category 2 response times, which is 60% of the activity and all of the urgent presentations, so not the really life-threatening ones, but the urgent ones. South Western Ambulance had a target of 30 minutes to deliver, which was the national standard. They achieved 37 minutes against that standard in March, but comparatively it was 46 minutes a year ago. So there's been big improvements that we've seen there in the category 2 response times. That's across the whole of the Southwest. In Dorset, we do particularly well with this. 28 minutes was what we delivered, so we were better than the national target for category 2 response times. And really, I think the main reason that we do that is because the handovers between ambulances and hospitals is really good in Dorset. That is done within 28 minutes on average. Now, the national standard is kind of 15 minutes should be the time that we hand over, but 28 minutes is considerably better than where it has been kind of 48 minutes across the whole of the southwest as an average, and that's because there are a number of about 3 hospitals that have got a problem with handovers. I think the one area that I would highlight as we didn't achieve what we said we were going to do was the no criteria to reside.
That was my question.
So we set out to get that down to about 12% of beds, which were about 138 kind of individuals in beds that shouldn't have been there. We were still at 20%, over 240, 250 individuals. We've got the Future Care programme, which is redesigning how the whole flow system works to improve that. But it was lower than what it was last winter. So it was about 30, 40 lower than what it was the previous winter. So we've continued to make progress. We started as an ICB at 370 when we first started 3 years ago. That is got down to this winter by about 260. Between 260 and 300 is where it fluctuated over the winter period.
So I think, is it, Dean, we've got the discharge hub working in the west now, and we're finalising the discharge hub for the east. And is that the thing we're waiting for to have the next push at numbers, or is it something else?
It should. That is the one thing that should have a real good impact on how patients can move through it, because what it does, it brings together in one physical location the people who can make the discharge happen, whether it is from the ward, from the hospital, from the discharge team, from local authorities, from voluntary sector. That is where.
What are the timescales now for implementing the discharge hub in the east?
End of May, I think, was the latest. It's already up and running.
Siobhan.
But I suppose ideally we would have had it up and running before we make the changes next week. But I understand it is by the end of May, which is really good news. I do just want to link this back to our earlier conversation, because we're talking about workforce and money. This is a significant issue. If in Dorset we manage to resolve this issue and deliver our plan, we absolutely would meet the workforce and the money. So I feel really strongly,
it's the elephant in the room issue for
focus on cutting workforce, but we're missing the point.
Yeah,
it's my point.
So the governance question is on workforce. Earlier, we thought we ought to have a little bit more than we're getting now, and can the chief execs meet, and can we have a bit of go? Do we need to do anything on no criteria to reside for a bit of additional feedback, or do you think implement the hub and see what happens? And what's your advice to us, Dean?
I think the Future Care programme is the thing that we should bring back. We've scheduled that back. I think it's in October to the Productivity and Performance Committee for the next view on the business case, because the business case sets out the savings that we'll make, which is predicated on reducing the no criteria to reside numbers for the delivery of the plan. So that's the governance that we have got in place for it. I think, as Siobhan has said, kind of there are changes that are happening at the moment that we need that in place. We've got the benefits realisation, and we are going over yesterday what the not what the theoretical benefits were in the business case, but what the operating plan kind of realisation of those reductions in beds and capacity that is required, that starts to kick in from May and June. And they're the things that we need to see happening. So I think we need to be tracking against the benefits in the business case, as we will do through the steering group on a fortnightly basis when we have the steering group. I think probably what we do, if we flag that we are not delivering that, then that should trigger something else, because that would be an escalation.
Really, and perhaps for the June, perhaps we can have an action today that your chief exec report in June will just cover where we are on tracking that. So is that okay?
Yeah, that's fine.
That'd be great. Okay.
We can do, Rob. I mean, I chair the steering group for Future Care, and I suppose that I would just say a couple of things to add to what Dean said. We sort of talk about it like it's a programme over here that somebody else is running, but actually all the SROs come with the programme.
Yeah.
There are people, and so some of the challenges that they've had are around individual organisations wanting to make decisions that are not in line with the programme and the business case that we've approved. So we've talked a lot about that, but I just want us to recognise that this is our programme, it's not Newton's programme. If we don't deliver it, we won't get the savings. All Newton are doing is providing the programme management support to it. We've identified now where all the cash releasing benefits will be and where they'll fall at an organisational level, and we'll be circulating that in the next week or two so that everybody can see where those core decisions need to be made within their own governance frameworks. But it's in our gift to make this work. It's not in Newton's gift, it's in our gift.
No, exactly. That was a really good discussion, and thanks for the feedback on end of year. Thank you. Forbes.
Yeah, thank you. It's helpful to have the conversation. Dean, I just wanted to ask a question specifically about Cat 2 response times. And, it is very helpful to see that there's been an improvement. But as a clinician and experiencing dealing with people who are acutely unwell, I think we sometimes present Cat 2 as not that seriously ill. It's not Cat 1, but basically Cat 1 is you're in cardiac arrest. And Cat 2 is you are still very seriously ill and you do need acute hospital admission. And you've often got presentations that the outcomes are time limited, particularly around an acute cardiac event or something like that. And I just wonder what focus is being put to bring the Cat 2 times down further, because I suspect what we're presented with is an average, and I have to say my own experience, when it works it's fantastic, but you can be waiting still with an acutely unwell patient for a long period of time. And that I know that's the experience of colleagues. Just to give you an example, a couple of months ago we had a lady presented to surgery very, very breathless, had an acute severe pneumonia. We were already onto our second oxygen cylinder. These are large cylinders, starting to think what we're going to do if we run out of oxygen if this ambulance doesn't come. And, so I'm just trying to give the sort of real life example of how important category 2 response times are in terms of acute care delivery.
Thank you. Jenny, did you have a contribution to make?
And in a similar way to Dean, I can update on month 12 finance outtime if it's helpful.
Brilliant, thank you. Did you just want to cover the category 2? Yeah.
Bob, you make a really important point, and the reason why we focus on category 2 is precisely for the reasons that Forbes has set out there. Kind of the category 1s are the life-threatening ones. They are kind of virtually all of those I got to within 10 minutes. Kind of they are the ones that they deal with, whereas these aren't. And this is 60% of the activity. Not all of them do need to go to, and there are some alternatives that some of those patients can go to, but the majority of them will go to a hospital. That's why there is such a focus both nationally and ourselves as lead commissioner with the Ambulance Trust over improving those times. There are probably 2 main factors in how quickly the Ambulance Trust can get to those, probably 3. It's the number of vehicles that they've got on the road, how many of those vehicles are already tied up, the majority being at the moment waiting outside A&E departments, which is why in Dorset we have such a good response, because we don't, as I've already said. And the third one is how long it takes an ambulance to actually turn itself round to be ready to go to the next patient. And they're the things that we are focusing on with the Ambulance Trust as part of the contract negotiations for this year.
Very good. I hope that answers for some of what you asked. Thank you. Jenny, you were just going to update us on the next iteration of numbers.
Always doing the new iteration. Because like Dean, I'm conscious that the report that went into the minutes is month 11. So to confirm, we talked at month 11 about how we were forecasting a 12 million deficit as a system. I'm pleased to report that's what we reported. So we've now submitted to NHS England, subject to audit, of course, who are on site, I think, at all organisations in Dorset now, and they're certainly on site in the ICB. So we managed to achieve our forecast that we set out to NHS England of 12 million deficit. That's split slightly differently across the system. So how that's sat is a 26.3 million deficit in the ICB, a 13 million surplus at Dorset County, and a 1.3 million surplus at Dorset Healthcare. It all correlates. Some good news as well coming out of the year, because I think we don't talk about the good news in finance enough. So the agency spend was a huge win for us last year, and Siobhan and Nick would both recognise that. As a system, we spent 29.7 million against our original plan of 38, which was already an improvement on the year before. And so in fact, we only spent 71% of our ceiling that is given to us by NHS England of our target of agency spend. So, you know, that was a really big achievement and took a lot of work to get to that point. We also achieved 138 million of efficiencies, of which 83 million was recurrent, which is a far improved position than where we were in 23-24. We know, as Siobhan said, we've got a much bigger target next year, but to put it into context, that was 6.9% of our allocation. So, you know, we did set out to achieve 168 million, hence the slight movement in our financial position, but we did achieve 138.
Good.
So I just wanted to recognise that.
No, thank you for recognising. I'm looking forward to the 25-26 results already, aren't you?
But happy to take any questions, because that was just anything.
Any questions? Anyone? Okay, thanks. I just had a performance question, Nick, on the spike in out of area placements. I don't know if you wanted to comment on that. Is that something that, you know, as commissioners we should worry about, or is it something temporary? What's your advice?
Yes, we made good progress in the year. The spike came through demand and pressures. I think it's something we have to pay constant attention to. I don't know specifically the driver for the spike you're referring to, Rob, but I'll go away and have a conversation with the team. But I can say that it's an absolute focus for the trust, and it's one of the key priorities as we go into as we are in 25-26 to make sure that we continue to focus on that, because it's a quality and financial driver for us. So yeah, real focus for us.
Thanks very much. That's appreciated. So there'll be a couple of action tracker points that we'll come back to, Liz, around things, but there were no items for noting or discussion. Hey.
Yeah, thanks, Rob. I welcomed the changes that we saw in mental health with regard to the children and young people and access to CAMHS, and I hope that will be maintained. I know it goes up and down through the year, and I know the same with eating disorders. This morning's presentation suggested that there was work being done on the dementia diagnosis issues, just as there has been on the children and young people. What's the time frame for that, Nick, in terms of getting that moving? Because that's been an issue for some time on the performance reports.
I don't know, Kay. I have to come back to you on that one.
Right. Okay. Thank you.
Thanks very much indeed, everyone. It's a really good discussion on some key areas of performance. Item 7, then, the intensive and assertive community mental health service review. Dean, I think you're... Hi, Mark.
I think you've disappeared during the break.
Mark, I'm Rob, the chair. As people ask questions, they'll introduce themselves rather than go around the table. Okay, over to you both.
Thank you. So just a very brief introduction. This paper comes as a result of a request by NHS England back in July last year. We've already received one report, which I think was back in November of 24, and as a result and this has come as a result of deaths that happened in Nottingham, from the an individual who was not engaging with mental health services, hence linking back to the conversation that we had earlier with Morad about people that engage or don't engage with services. So this is why it's here is a particular governance issue, because we need to have signed off this report, understand what it's saying and seeing what it's done by the end of June. Mark will talk us through a little bit about what's in the report.
Dean, so I'm Mark, Principal Commission Lead for Mental Health with the ICB, and it was good to, I think, set the scene for this from Morad's presentation. Sorry, button. I'm Mark, Principal Lead for Adult Mental Health Commissioning with the ICB, and this is an update back to the board. We came in November of last year, and like Dean said, we were asked by NHS England to review our community mental health services on the back of the homicide in Nottingham. And what you'll see in the report is there was also CQC required Dorset Healthcare to review their services as well of the same topic. And there was another homicide as well that was reviewed by Niche, where the individuals were under the care of mental health services with Dorset Healthcare too. So we decided it was sensible to combine those pieces of work into one plan, because a lot of things were coming out that were similar. And the report really describes the process that we went through to review that and co-develop an action plan. You'll see the action plan is in the papers also. It's big. There's a lot of actions within it, which I think illustrates some of the complexities and challenges that exist across community mental health services as well. Morad described the good stuff that's happening in terms of access wellbeing and community transformation, in terms of open access and the sort of the front door type stuff. There's still a lot of work to do in the sort of the more clinical services as well. So hence why I'm here today, just to present that to the board, have a discussion about it, to take any questions that we can take from there.
Yeah. Questions or comments, please?
Thank you. It's really a comment. I think, you know, none of us can underestimate what happened in Nottingham and the impact of it. But I think what we also need to recognise with serious mental illness, that we can never say it will never happen on our patch. We can reduce the risk of it. But I think there's something about the language we use, that all of these actions, everything we do as partners, this is about reducing risk of it happening rather than preventing it from ever happening. Just important for the board to be cognizant.
Yeah, that's a really important point, because all of the community transformation that we're talking about requires quite a fundamental culture change in the way that services are delivered. We can do everything we can to try and safeguard from risk and support people to engage with services, but at the end of the day, it's all of our own responsibility for our own mental health. And you'll never be able to, unless you detain someone and put them in a room and lock the door, you're never going to completely mitigate those sort of situations. So I think what this demonstrates is that there's all sorts of mechanics and processy type stuff that we can do, but it also requires a huge culture change. And the mental health pathway is multifaceted. It's not only the responsibility of Dorset Healthcare as a secondary care provider, it's primary care as the voluntary sector, it's all of us as people living in communities as well. So it's a complex but interesting and exciting opportunity for us to reset that and change the way services are delivered, I think.
Yeah, thank you. Other questions? Siobhan?
I found the conversations around mental health really fascinating this morning, and I suppose it's made me reflect a bit. So as Dorset, do we have a sort of clinical strategy around mental health in Dorset? And you mentioned sort of mental health pathways, and I suppose I'm relatively new to the system still. And I just wondered, so at an ICB level, I'm not sure where the line of sight of those pathways are. So it's stimulated my thinking into, because also in some areas, because I think, you know, this area and really severe mental health at the moment, you know, A&E attendance is the wrong place for people. And we still have significant issues in Dorset. Actually, do we need a debate about what is the model of care for those patients? How do we really radically have something different in Dorset? And I just wondered if there's a place for us to have some of those conversations.
It's a really important point. I think there isn't a strategy per se at the moment. There is the mental health, the MHLDA steering group, which I chair, and then there's the MHLDA delivery group which Matthew Bryant chairs with colleagues as well. There is
worth picking up. Sorry, Patricia.
I was just thinking that whilst we might not have a strategy, we've got the adult mental health transformation programme that's on its way, and then we're just about to bring the business case forward for the children and young people's mental health. So there is something about just taking those two business cases and sketching out what the model will look like going through that process, because we have got that, and that to me is as good as a mental health strategy. And it's about being really clear what the delivery model needs to be and what the population health outcomes are that we're aiming for. So there's something about the sketching of that, isn't it? Just like we're doing with the UEC services, say this is what those services will look like when those two programmes are concluded.
And if I can, Dean, and then invite you. When I chaired the East London
sort of tried to deal with your questions, Siobhan, about the most appropriate place for care. I've of course been in UHD A&E where we had to close it down, and where sadly somebody who probably doesn't have a physical need at the hospital needs to be sedated because of the amount of distress and crisis for them. And we don't want that as a system, do we? And so I think a discussion involving the ICB about how, as a commissioner, where do we think mental health patients inappropriately being dealt with in A&E should be seen. We also have a discussion about that. Maybe we could, task the trusts with ICB help to talk about that for future commissioning intent. But you can answer that, or anything else you wanted to say.
Rather a large question to answer, I think. But I think in terms of the way that we're addressing it, what we set up as part of the system operating model was the mental health delivery group, which is three-way chaired between voluntary sector, local authority, and the trusts. And the Mental Health Trust, Dorset Healthcare. I think that's the mechanism that we should use to do it, because that has got all the partners around the table. It reports into the system executive group, which is where all the chief executives sit together. Over the years, as we've had the mental health investment standard, we have reviewed many of these services. So we've done the adult services, which has resulted in the business case that we've got that's now being implemented with the Access Wellbeing. There is the transformation programme of the community services, which is underway, not yet completed, and probably needs to be kind of more make sure we're focused on delivery of that. And we're just completing the end of the children's business case, which was to extend particularly the CAM services to create what's called the Thrive model, so that we've got one access point for all of those services. So I think, as Patricia has said, we've been through that process. Once we can see the end of that, I think then it's almost to go back and say, so what have we got in place? Is that right? Where do we need to go next from? And it feels like once we've got the children's mental health one kind of sorted, then that's the right time to go back and be asking those questions. How does the whole system fit together?
That's really helpful. Thank you. I've got Kay.
We have Kay, and then Forbes, and then Nick. I'm very sorry. I always think my voice will carry. Kay.
Yeah, thanks very much, Rob. I absolutely couldn't hear anything at all until you turned that on.
I'm so sorry.
It struck me reading this that a lot of this is a comment rather than a question. There's a lot of what was in this report with regard to patient feedback is true of all of the services we've got, not just mental health. It's across the system, this issue of not having to tell the same story again and again and again. And when Mark was talking there about cultural change, it strikes me that has to be that kind of cultural change across the system. So we need to do something with this that is broader than just mental health, because we've heard it so often. And we can't keep going back to people and they can't keep telling us the same thing if we're not actually trying to address these kind of issues they keep raising. And it was just a comment that this is more than just the mental health. We need to be taking this on board for all of the system. Thank you.
Thanks very much. Forbes.
Yeah, thank you. I thought I'd wax in my ears when I couldn't hear you, but obviously it wasn't here.
Schoolboy error, I'm afraid. I'm very sorry.
I was off down to the nurse to get
I'll claim it's because I'm new.
Yeah, it's just a general comment, and I know it's work in progress, but we've heard a lot about mental health this morning. It's been very interesting, but for me, the more we can do to wrap mental health services around general practice, the better. We can absolutely work on people's health and well-being, and there's no doubt we can reduce crises that end up in ED because perhaps we've not got the wraparound around hospital services. And the integrated neighbourhood teams are an absolute platform for that to happen, working with general practice, community mental health services, and the local authority services as well. So we've heard about that this morning. It's what's What's the driver for someone's mental health issues? It's often a wider determinants of health issue rather than a primary mental health issue. And the more we can coordinate that care, the better. And do that hopefully around the hours that general practice has to be open as well. So we can offer something in the sort of twilight hours at the end of the day as well.
That's really helpful. Thank you, Nick.
So in terms of the review, I was just going to say that certainly from a Dorset healthcare perspective, the action plan is connected into our governance processes through committees and into boards. So there is oversight in that way from a DHC perspective. And the report notes the need for kind of system partners to lead in and support as well. So that's really positive, and I think the teams have worked well together developing the action plan. The second point I was just going to make was similar to Dean's and Patricia's. I think we do have kind of the parts of a strategy from a mental health perspective. I think it's probably just about how we codify them and then give them the right level of visibility as we go forward.
Thank you. I don't see any other. Yes, Mark. Can I just say, I think this has been a really good discussion. I was helped by the platform of the review. And really good to see progress and also get rich comments from people about taking it forward. Mark.
Thank you. I just wanted to summarise and close by saying that I think someone mentioned it earlier, through the adult transformation programme and the upcoming CYP one, we didn't pay enough attention to the cultural bit or the people bit, and engaging with the workforce. So engaging with the clinical medical workforce is really, really important, because if you don't engage well enough with those staff groups, you'll always get what you've always got, because those services are required to work fundamentally differently. We're having lots of conversation in the ICB about outcome-based commissioning, and in mental health, that mindset is already there. We've now got to move to the next bit, which is services operating and delivering in a different way. So they're not delivered in a siloed way. The mental health pathway is one pathway, but it has different sections in it, and those sections often don't talk to each other, don't integrate or align properly. There's lots of crisis services which exist, but they're not used because we don't broadcast it enough. People rock up at A&E because they think that's a safe place to go. So there's a lot of good stuff happening, but there's still a hell of a lot to do as well.
Thank you very much indeed. Okay, we'll move on. Thank you very much. Thanks, Mark, for joining us, and thanks, Dean, as well. All right, so we're in the home stretch. I don't think we have any items for consent, Liz, that we need to deal with. We come on to questions from the public. We've had two. First one, could it be considered that the name mental health can be changed and categorised as not one size fits all? A different name for trauma mental health. Can trauma mental health patients be more involved with giving advice on what care we feel we need, because we are getting the same as non-trauma patients and it's not working? There is a response to this, and obviously always happy to follow up more, that the name or term mental health is used as a generic descriptor across the NHS for anything relating to someone's mental health and or psychology health and well-being. In Dorset, we're currently mobilising a new complex trauma pathway where people can get the right support suitable for their specific needs. In addition, there is the ongoing rollout of trauma-informed training across NHS and voluntary sector services to ensure that people get the support suitable for their needs. Also in Dorset, we do work with peers and experts by experience, that's the name of the group, as you can see on the slide, to get the views and perspectives of people who use services, helping us to co-develop service transformation and improvement plans. We would always welcome talking to people who would like to get involved. We have a second question. We can flash that up. Thanks very much. Given that there is no dedicated pathway or multidisciplinary support team for the management of venous leg ulcers among homeless patients in BCP, how does NHS Dorset ensure equitable access to timely, effective wound care
for this high risk and often hard to reach population? Thanks very much for the question. The response is that homeless individuals can access the service through their GP and referral to the Dorset Healthcare Leg Ulcer Service or district nurses. Care is provided at GP surgeries and by district nurses at hostels. We have a dashboard drawn from general practice data identifying 134 homeless individuals with a current or past leg ulcer, and the health bus reports approximately 100 patients receiving care for this condition. We're currently reviewing the leg ulcer service and pathway, including related aspects of lower limb health. This includes consideration of access of services for all those that need them. A new draft service specification is in development and will include a specific requirement that providers consider access and outcomes from services for priority groups, including vulnerable and inclusion health groups, such as people who are experiencing homelessness. We are currently testing new models at 2 sites in Dorset, and this will be used to inform finalisation of the service specification. We thank partners, including the Health Bus, for their input to date into this review. Thank you very much for both questions, and thank you for this question. I didn't know about the Health Bus. That's fantastic. What a great piece of work taking place. So thank you for the question, and thank you for those who drafted the responses. I'm not aware of any other business. Is there anything? Please. Thank you very much. Key messages. Is there anything you wanted to feed back to us in terms of things you've highlighted from your notes?
Yeah, can do. So we've got usual minutes and actions, which will circulate in the usual fashion. I thought in terms of key messages from today, in terms of the national and regional context, we noted the complexity of the challenges relating to the ICB cost reduction requirements. And we also welcomed University Hospital Dorset's progress with the Transforming Care Together programme and also the ICB strategic commissioning intent. We welcome the powerful mental health stories and the deep dive, considering the relationship between community services, acute and third sector, and the role of community in supporting mental health, and also the risks around over-medicalisation and engagement. We agreed to maintain the current board assurance framework until the new strategic direction was set, and we also considered the strategic and operational risks relating to transition. In relation to performance, we focused on the risks relating to delivery of whole-time equivalent reduction, and we requested the CEO's and ICB governance oversight of this. We also considered no criteria to reside and the anticipated positive impact of the future care programme on this, and also the factors contributing to the Category 2 ambulance response times. We welcomed the finance report of ending the year on plan, a 12 million deficit position, especially welcoming the reduction in agency spend and recurrent efficiency savings. And we also noted then the co-produced intensive and assertive community mental health service review action plan, noting the underpinning need for a culture change to transform these services. And we also considered how a delivery model could flow out of the adult and children and young people's mental health programmes via the mental health delivery group.
That's very helpful. Thank you very much. We finished bang on time. Well done to you all. You get a chair's pat on the back. Thank you very much. We're due to start at 2 o'clock. Rachel, you and I are in a Southwest Chairs meeting, and so if it goes to 2:15, I might come back and start part 2 on time, if that's all right, rather than hold everyone up. See you at 2 o'clock. Thank you very much.